at 9. Call the meeting to order at 9:03 a.m. Welcome, everyone. I think we all know each other. First up on the agenda is approval of the minutes for October 3rd, January 22nd, and April 21st. Do we hear any changes or a motion?
I'll move to approve the minutes.
Second.
All those in favor say aye.
Aye.
Aye. Motion passes unanimously. All right, next up, we have Health Department update and celebrations.
Good morning, Commissioners. Rachel, Lacey, Sam, everyone online as well. So just to clarify, I'm not Sarah Hartstein. I'm April Holland. I'm serving as the Health Department Director. I let the chair know about the change in the agenda. There are a couple of other meetings happening right now with IHN specifically and with discussions around federal funding impact. So I asked Sarah and Damien to listen in for their divisions respectively. And Jasper will be joining remotely to be present with his team right now. So a couple, just kind of wanted to bring us all up to speed on happenings over the last quarter since we last met. I think the first thing on my list, I think actually happened just before our last meeting. So it's a little bit out of date, but we celebrated the grand opening of the Barbara Ross building at 4185 Southwest Research Way in late April. That was a wonderful celebration. Thank you for your participation and support of that space. Everyone who works in that building at the Children and Families programs lovingly refer to it as the Barb, and really are decorating the space in ways that are really child and family friendly. I don't know if you had a chance to enjoy the self-portraits done by all of the staff members outside the entry there, but it's a very welcoming, very sweet space. The other major new building opening, of course, was the Crisis Center. We had the ribbon cutting ceremony, as well as a grand opening kind of weekend. So many folks contributing to the work of those days. Thank you for your support in those efforts. The building is up and running in terms of business as usual right now. Our new crisis programs manager is getting her feet under her. She came from Deschutes County and worked in their crisis and stabilization program there. Her name is Haley Clark. She's doing a great job, and she's got the support of not only a working out of class manager who's very seasoned and has worked as a lead in the crisis program, but also some extra support for policies and procedures and just the operational needs that pop up in a new space that aren't always anticipated. So Ricky, always something. So Ricky Garcia and Ashley Talamontes are providing some extra support as well. And on the Crisis Center operations side, there's a lot of work happening. Behavioral health is related but not directly related to the Crisis Center, is working on adjusting its rates. So it's there'll be a contract with an agency that helped both Lincoln and Lynn counties conduct an assessment to determine where their rates should be. The rates have not been updated in a long time. So where this does connect to the Crisis Center is when those rates are modernized, we will be poised to have better reimbursement for the services provided. There's also ongoing talks with IHN about operational support for the crisis center and its programming. We've got an initial application in with a lot of information that they've requested. The idea is what we're expecting is to get an initial award, and then with the rate setting and some additional information coming from OHA, we'll revisit, the initial award probably in January. Moving on, the Coordinated Homeless Response Office has been, well, first, I just want to celebrate that the flexible housing subsidy pool's goal of 51 households has been exceeded, and they house 53 households, well over 100 individuals receiving ongoing support, and have a place to live. The coordinated office has also been working very closely to reduce a gap in service of our sheltering with Unity Shelter. The work has been very much a coordinated effort, working with the office of the OHCS at the state level, as well as the city, being really creative, innovative with the use of some of our grant funds, as well as creating an understanding through contract language of exactly what it is that we need and expect from this very important service. So lots of pieces in motion there. At the next HOPE meeting, the coordinated office will be speaking in more detail about that path and where things are now. We also wrapped up across health services our Courageous Conversation contract. We had two-day trainings, as well as several opportunities for not only preparation and feedback sessions afterward, but opportunity to have some one-on-one guidance on some of the tools and lessons learned, so that we can walk away with as much useful information to operationalize and embed equity into our day-to-day work. The health department is also working on a communications plan, and they've done a great job, as a Healthy Communities team does, of engaging a broad audience internally, as well as with partners. It's really, their assessment is really thoughtfully done, and we'll see over this biennium a lot of training and empowerment of program staff to conduct communications in the ways that previously, have been hard for folks to do without relying on a couple of people. One, and then the final thing that I want to share, I don't want to take the whole time, is for behavioral health, there is a big change coming to the state agreement, the financial agreement. There's been a lot of controversy over this change. Previously, behavioral health was funded with service elements for the various bodies of programming, and this is moving to sort of broader domains of programming, as well as a prioritization of the behavioral health services, according to OHA. I think the sticking point is really around whether these services will need to be provided, whether funding is available or not. And so as this issue continues to be discussed, OHA has provided a 6-month extension the current funds. And during that time, behavioral health is tasked with writing a plan based on the new domains, as well as a budget based on the new domains. So Damien and I have met to outline his plan moving forward to meet with various folks across health services. There's a lot of pieces that touch behavioral health to make sure that from prevention to crisis, that we are meeting a spectrum of needs for behavioral health. I think that's it. One thing that I guess I did miss is our public health accreditation, reaccreditation is underway. We've got a site visit. It is a virtual site visit, which is kind of nice. And thank you to, I think a couple commissioners will drop in for exit interviews for at 15-minute increments to meet with the reviewers. But there's a lot of planning underway for that right now. And I think that's all I have in terms of.
Question, when you're talking about the language of whether money's there or not, has that been decided yet, or is that still in contention? Because we've received emails from AOC requesting that we don't sign any contracts until this is worked out. And I was wondering where that is currently.
Sure. So there's no new CFAA language grants. These are just extensions based on the service elements. It's all previous language and it's just for the 6 months. So
Okay.
It's an extension of the previous contract.
So didn't agree on a new contract, extended the old one for 6 months, and there isn't any word on whether the language is going to be in the new contract in 6 months.
That's right. We're still required to draft the plan. And so we'll be coming back with that drafted plan, knowing that the overall points of contention haven't been.
Cool.
Yeah.
That doesn't feel like a good use of people's time, but
It's challenging.
yeah, that's okay.
What was decided upon and directed.
Yeah, so which department are you dealing with on that?
OHA Behavioral Health Division.
And kind of the governor's office itself too, is my understanding.
Right, yeah, in terms of the new CFAA and the challenges therein, I think that really AOC has been taking the lead on that. I have been really in close contact with Rick and others and following AOC and let him know that we'll be waiting on county guidance before we sign. And we want to make sure that this issue is resolved.
But AOC is doing a good job.
They are
Advocating. Yeah. I think the idea is they want to be ready to press play once they have an agreement. So they want the work to be done. So that way we can put it into practice. But seems like they're optimistic that maybe the advocacy is working. I don't know.
Seems like it, and then, but the language hasn't, there hasn't been any movement yet.
They said like 30 out of the 32 counties that it's relevant for have refused to sign anything. So there's a
Yeah.
broad coalition of.
Yeah.
Yeah,
Agreed.
Gina had reached out sometime ago and just said, hey, can you make sure your people aren't gonna sign anything? I said, oh, you already knew everything. It was perfect.
That's right.
Yeah.
It was Gina, sobering first read.
Yeah.
I had a question back on the crisis center and the funding, and so even though it's a shiny new building, we've had the service before. And so we have some examples of how the funding works, and we provide the service and then submit something and at some point get reimbursed. What kind of time lag is there on providing service, billing, and receiving the funds?
Sure. So that's exactly why we have some funds in reserve, because there is a lag with those things. In terms of the exact timeline, I would need more subject matter expertise to tell you what that looks like. But part of it is the reimbursement piece. The other part is ramping up the services to get it to the point to where our projected revenues are where they will be. And so we know that we're going to eat through a lot of that initial fund, because when you move spaces, uh, the number of clients seen, won't be exactly where they were previously. And then adding new staff, conducting more outreach as we're doing right now, will start to bring more folks to awareness of the services. And then when stabilization, when those seats are open, then that's obviously more revenue that will come in. But we do anticipate using a large amount of the contingency fund to make up for those lags that need to happen as the services ramped up. And I know that we've talked about this before, but I think it's really important in this time in particular to proceed conservatively and with caution. The last thing I want to do is to push the gas really hard on increasing services without knowing and having really high confidence that we are going to be able to meet all those operational needs. So if we need to go more slowly, then we will.
And you mentioned something about initial award. Is that part of this cushion to help with the lag and you have expenses before you have income?
We already have the cushion. This would be to help pay for operational needs beyond the cushion. So we've got some money in the coffers to help with this initial startup phase as is.
Do you know what the initial award amount or?
I don't yet. I think that's what's, those are conversations that have happened, just about every week, at IHN. We've been really transparent, and provided a lot of data, and, are looking at, an award that works for the current services and then the services to include stabilization. So I imagine that there will be a phasing of those different levels of payment based on what services are being offered. But we did just onboard, we are going to be onboarding the new first new batch of staff. And
How many?
just
A batch. More than one, it's a batch. If they start at the same time.
We're here. Yeah. Oh, that's good.
it increases capacity, which is
Throughout this project, it seems like we've had good support from the state, like on the building. Is that good support? You feel like it's continuing and?
So the complexity, I think, of what we deal with now is that we're on a reimbursement space after that. And so how the state gets their funding through block grants, and then that passes down through if conversations are just nuanced with IHN, because you can't provide operating dollars if it's something that can be reimbursed through like a traditional medical reimbursement structure. And so it's both things have to happen at the same time. So you have to work on getting your service delivery up and moving, and then negotiate that reimbursement rate to be able to sustain the cost of doing business. So now it's kind of moves out of the state's hand and more into the program and the CCOs who are responsible for funding the they're great at capital things. And then this is the part that is just a little bit more nuanced.
It is, there have been conversations over the last couple of years around, support for crisis centers and changes to rules and what can be billed for and those sorts of things. We haven't seen any huge shifts yet. And there's also been conversations around appealing to the governor's office for funding for crisis centers. And I think in this environment, that's not something that we should count.
Well, I know the social media reach has gone pretty far. I keep hearing, I heard last night at the library board, someone saying, oh, I keep seeing it all in my feed and people sharing it. And it's really nice to have a win and something that people are excited about and that people are like, hey, good job. Because it seems like that's far and few between in government. So thanks for at least giving us that opportunity.
I brought it up at the beginning of all my town halls. I talked about what the county is doing and I bring it up, and at none of the town halls did anybody go like, that's a waste of money or that's a bad idea. Like even all across the county, people are like, oh, okay.
Yeah.
And that's the like baseline reaction.
Taking all the
Like,
money by other.
yeah, that makes sense. And I'm like, great. That's it.
And the Barbara Ross building, another win, that's, yeah.
What's Good Sam's role? I mean, I assume it's indirect, but I mean, they are involved. Is that accurate?
They're great partners. They're very important partners. Certainly our crisis team engages with Samaritan on a daily basis and they're a critical space for individuals who may present to need crisis services and that sometimes is the appropriate level of care. So in terms of that relationship, that they're very closely connected to the crisis center work. In terms of, in some crisis center like situations, they may get to a point to where the utilization is helping to offset burden on emergency departments. And I think that's something that we should keep in mind as our operations expand.
Would somebody go to the crisis center and then they get evaluated and end up at Good Sam?
Absolutely. It really, first of all, the crisis center is voluntary, of course. And the licensed professionals there are going to conduct an assessment to determine the appropriate level of care for an individual. And that might not always be, it might not end at the crisis center. They might need another level of care, and that might be the ED, it might be another facility elsewhere in the region or state.
Thanks.
Any other questions or comments?
Sounds complicated.
What's not?
In case you didn't know.
All right. Well, I think we can move on then to community health centers update and celebrations.
Yes, so we have a few highlights, things we want to just go over with you all. Thank you very much for your proclamation earlier this week of National Health Center Week here in Benton County. We've been doing this work for 60 years in the United States and 21 years here at Benton County, so that's very exciting. We're also really happy to have one of our patient board members, Grace Robinson, here. She has been a new board member this last year and has stepped up. She's our secretary and to leadership role. She's doing a fantastic job. We're happy to have her. Other things we're doing in terms of Health Center Week, we're at farmers markets across Benton and Lynn counties. Thanks, Commissioner Shepherd, for visiting us yesterday. We've got some sports physical clinics happening at our school-based health centers, and have been at the Sweet Home Community Health Fair this month also. Other things, we've mentioned it a time or two, and Commissioner Shepherd, since he sits in our meetings every month, is well aware we have our HRSA operational site visit that's coming up here next month, September 9th to 11th. And our federal representatives will be on site. They just actually were given the go-ahead to travel, apparently, federal employees, this month of August. So this will be the first on-site visits since January, the new administration. So a lot of work and preparations going up into that. A couple of staffing updates I want to share with you. Christine Mosbaugh is our work out of class interim primary care division director, effective in August. And we're working on getting that recruitment up and posted. That's formerly known as the deputy director of clinical operations. That was my job. And one of the many jobs that I'm happy to not be solely doing. So it's like a few of them, but I'm grateful for Christine's support. We also had a transition of our health finance officer. Ahmed Zabari went on leave back in March, and Debbie Sessions stepped in to help support that work while he was out. He since resigned in June, and Debbie is serving as our health finance officer right now. And then we're working with Rick to get that recruitment started. So I cannot say enough how grateful we are for Debbie and the work and leadership and support analysis, all those great things that she's done for us. Debbie has been in interim, CFO roles and other things. And over the course of the last 18 months, she has dove in and learned and sat alongside us in so many different ways to understand health center finance. And so anyways, I'm very, very grateful for her and her willingness to continue to do that work.
She has a lot of varied experience.
Yes.
Definitely is willing to fit in.
Yeah.
All kinds of internal,
She's
Yeah.
a problem solver.
Yes, she is a problem solver, yes.
And enjoys
The challenge
The
of
challenge,
the problem,
Yeah.
yeah. And she gets it done quick. Which is great, because we usually ask her for something with like an 18-hour lead time. So that's bad and great.
That's my experience too, yeah.
And then we also hired a new dentist, Dr. Tara Bobble. She started with us in June. Her partner works at Good Sam as an anesthesiologist, and she came from community dentistry back in the Midwest from Ohio, and had been working in Lebanon, but really wanted to get back into community dentistry, and she is fantastic. We are so thankful to have her. Just a great representative of the work that we do here at the county and in health services. So some notes of celebration. We just finished our patient-centered primary care home attestation for 2025. And these are national standards for patient care home model, but Oregon Health Authority kind of modeled this behavior earlier than the rest of the country, and so they have a very much more rigorous process for attesting to be a patient-centered primary care home. And we have been then there were new 2025 criteria. We went from, I think it's like a 120-point system to a 325-point system. So just a lot of things to attest to, and you have to submit documentation for all of those things. And are a great team of site managers and all of our or CHC managers and our admin staff really helped make sure we could submit everything. Health Services Building and Lincoln Health Center have been Tier 5. This also ties directly to reimbursement. So as long as you have one Tier 5 clinic, you get paid and reimbursed at the highest level. And Lincoln and Health Services Building have both been Tier 5 for some time. It may remain Tier 5. That's great. But Monroe Health Center and East Lynn Health Center both met Tier 5 criteria. And that was a goal of the site managers and the care teams to be able to do that over the last year. And so we're so proud of them. East Lynn actually had to have a virtual attestation process that they had to go through, and they did a fantastic job.
Do you have any like easy examples offhand of what the difference is between like a tier?
A Tier 4 and 5. So a tier, it has a lot to do with coordinated care and demonstration of coordinated care. So case management, interdisciplinary care teams. So our care teams are not just your provider and your medical assistant, it's your nurse and your behaviorist. I see Shelley's on here. She's one of our behaviorists out at East Lynn. Your health navigation folks, so where everybody comes together to wrap around and make sure that patients are getting the services that they need, but then they really just are following through and auditing patient charts to see that what you have written in policy, you're actually doing for a vast majority of the patients that you have. I think the only reason Sweet Home didn't meet it was because we had intermittent providers for about 6 months between Dr. Kelly and now we have Kathy Thompson out there in Sweet Home. So our hope is that the next time we attest, we'll be able to get Tier 5 everywhere across the board. But there's a new designation that came this year, which is the Health Equity designation, and Health Services Building in Lincoln Health Center were both awarded the Health Equity designation. We just found out yesterday. And they have to meet 20 criteria, which have a lot to do with access and inclusivity, language and communication, equity-driven data and care, so that we're monitoring things, culturally responsive and patient-centered care, and then that we are partnering with our community partners, as well as the state and our CCO.
It's the state designation.
Yeah.
Obviously.
Yeah.
Yeah.
The state.
I wrote that down as a question.
Yeah.
You said it was Lincoln and who else?
Lincoln and Health Services.
And
Building.
HSB.
Mhm. So, great work. We've been doing that for a long time. So, another update for all of you, the Monroe Health Center. So we completed our NEPA and environmental surveys and just went through the RFP process for signing with an architecture firm. We're really excited. We went with Clark Kojos, I think is what it's called, Kojos. Anyways, we had 3 architecture firms bid. The one that did Health Services Building remodel back in 2019, the folks who did the crisis building, and then Clark and Kojos is a new one to us, but not new to rural health centers and school-based health centers across Oregon and Washington. So they have been doing community health centers for quite some time and really clearly demonstrated an understanding of the services that are going to be provided and the environment in which they're going to be provided. So we're really excited to get moving with that, as are the staff. So those are our next steps there. And then the last thing that I have to share with you all is that you we talk about this every time we see you, but we did receive our final approval letter from the state for our new PPS rate. That, we've been working on that for 18 months. We did end the fiscal year with a positive ending balance for the first time in nearly a decade. So without the books being fully closed, I'd be happy to write down the number and slide it over to you. But it's good.
Anybody haven't happened.
Yeah. I think Debbie will, eventually you guys will find all of that out. I'm happy to let you know, but we, all of the hard work that we did is putting us in a good place to start this next year. And especially as, things are a little bit unknown in terms of where the next couple of years will take us, and the next biennium after here, puts us in a good spot.
On the Monroe Clinic, there's a funding gap, correct?
There is, there's still, it's about 750,000, ish, I think. I know that, Merkley, has it Merkley? I'm trying to remember. Anyway, there is a request
I think it was
in,
Merkley.
I think it was Merkley, yeah. There is a request in the, FY 20, is it 26? Is that what they're gonna vote on in sometime soon? Who knows?
Yeah.
So there's a possibility for some additional federal funding in that space. We are talking with IHN also, because this is a capital situation, to see if that's a possibility. If not, we're in a good position right now to be able to fund it ourselves. So we're feeling positive, and don't feel like this is a risky investment in terms of our own revenue.
I know we toured the Monroe Clinic with Rep. Gomberg,
Uh-huh.
who's pretty good at putting funding packages together. And I lost track, but he had $600,000 for ALSI.
That didn't get funded.
I heard, and that may be separate, but there was a mix up in the speaker's office, and his package that he had put together and was
Mhm.
moving along. Somebody didn't put it on the list,
Oh, okay.
and so it was very sorry.
Oh, okay. Huh?
Next year,
Uh-huh.
it should get funded. And so active, there's 700,000 there and 600,000, and it's not clear what LC would do with $600,000.
Mhm.
Is that worth conversation with Rep. Gomberg?
Oh, I mean,
Does-
absolutely. It needs, if there's.
Those numbers line up
Oh, sure,
pretty
sure,
closely.
sure.
And I'm sure he would love to be the funding source that puts you over the top on the project.
Yeah, I mean, the state has a proven track record of really being invested in school-based health centers and in rural healthcare. So I think that would be definitely worth a conversation.
Total is about 3 million.
Mhm, mhm.
So
Yep,
We have 2.3.
yep,
Ish.
yep.
Okay.
Awesome. Any other questions?
Yeah. So question about the HRSA visit. Are they political appointees or are they staff, like,
That's what I was wondering too.
yeah.
They are.
Do you draw?
Were they hired in the last 2 years?
They're employed at HRSA. I don't know. A few of them are consultant, I mean, like, so there are
Okay.
technical consultants that have contracts with HRSA, and the ones that we met with have been doing this work for a long time. So
Okay.
this isn't their first rodeo. And then we have a HRSA representative that we've never dealt with before, but they're just overseeing our visit, but employed through HRSA or Bureau of Primary Healthcare, actually. So and has been with the Bureau for a few years.
Okay.
Yeah.
And did HRSA end up getting rebranded and removed around? Did that actually pass or like?
Well, it's in the, it will be in the it's in the spending package for FY 26. Is that what's coming
Yeah.
up here? FY
That's the September one.
That, yeah. So that's kind of where the whole budget structure is at. So once the spending package gets approved, that's how they submitted it, as we understand it.
So it
But
didn't go through the reconciliation thing.
no,
Okay.
not that I'm aware of.
Okay.
Mhm.
All right.
Again, not that I'm aware of. I shouldn't say no. I should just say, not that I'm aware of.
And for both of you, were you able to convey needs to Congresswoman Hoyle on Tuesday in that?
Yeah, it was a good conversation. I think, the door is open to have conversations, and certainly, I think as we face, issues of, slow drawdowns and, that sort of thing, that her office is always very responsive to us, about those sorts of things, these kind of bigger things that are policy driven. It makes it really hard. She's one in a sea of, other things, but certainly, she's been very responsive to the CHC, to the Oregon Primary Care Association. Her office is very responsive, when we've asked for support on things. So both as a health center locally and, for all the health centers in her district.
Seems like when she was here, the more specific and narrow the problem or the question, that you can get the issue.
Right.
That
The more help that they can provide. Absolutely. Yeah.
first being.
Yep.
uh, But specific
Mhm.
um, requests. And I've seen her in action, and she's just very practical.
Yes.
Let's get this done, and even in current DC is able to find allies to work on issues.
Yeah, she gets stuff done. And we're very grateful for her support in the Monroe Health Center. She's the one that was able to help us get that funding across the line there. So for that initial award from the USDA. So absolutely.
Okay, any other questions or comments on that agenda topic? Since our next one's set for an hour, I think I'm gonna call for just a short break.
Okay.
Sure.
Thank you.
All right, we're back, ready to get going again.
Sounds good. I'll let Sam pull up the PowerPoint here, I think. I'm gonna follow along here. That way I don't get lost on what's coming up next. Okay, there's a transit. Oh, it's me. Sorry. There we go. Look at that nice animation.
It's
We're
working.
gonna, yes, oops. Is it, okay. We got a little bit excited here about okay. I think usually you have to have animation on one slide, the title slide, so my apologies. So just wanna let you all know, we're gonna give you an overview of some of the real-time updates that we have. Some of this stuff is new from last week, some of it's new from Friday, some of it's new from Monday. But every day is kind of a different challenge, new things that we're learning. Again, just wanna let you know that we're getting our information from attorneys, policy experts, advocacy groups, partners, and OHA has stepped up also and provided us with some information, which we're gonna let you guys know about here. Yes, things are evolving and changing. As you all probably are aware, or should be aware of at this point, the One Big Beautiful Bill Act, or HR1, or as federal agencies are being directed to call it, OBA, was passed on July the 4th. And anyhow, this is definitely a continuation of kind of the first term tax cuts and spending from the first Trump administration, and definitely has a lot more impact to federal programs. And we're waiting on guidance from federal agencies like CMS and Health and Human Services, in order to know how many of these things are actually going to be enacted. Our partners really call this death by 1,000 cuts at this point. So a lot of kind of the big poison pills that were in there were not included because of state parliamentarian, I think, who showed up as like a hero for everyone at the last minute, pulling some things out of that bill that weren't eligible, including penalizing states who provide healthcare services for undocumented folks. So there were some wins that came out of that.
It could have been worse.
It could have been worse.
Yeah.
Absolutely. It could have been worse than bad. That is exactly it. There are new crackdowns, right? Limitations, a lot of limitations were put into place on who's eligible for Medicaid. Most of the bill is being that's being impacted have to do with cuts to Medicaid. So let me put that out there plainly. There are new eligibility hurdles, which we'll talk about here in a minute. Eligibility requirements for non-US citizens, and then some crackdown on states and how they're able to use provider taxes to finance the non-federal share that states pay for Medicaid services. So
The 10%.
The 10% didn't, that was for folks who do provide services for undocumented folks. So they didn't take that in, but they did eliminate, they're putting new rules on how they're able to use the provider taxes. So not necessarily a reduction in them, but how they can implement them. So Oregon OHA hosted its first meeting to talk about anything with the folks that they partner with about these new changes, and appropriately so. They were waiting to see if the bill passed and kind of how that would impact services here in the state. We'll kind of go through the timeline of how these changes are going to have to be rolled out, and initially kind of what OHA presented as their response, but things that are happening within this plan year that are significant, and that OHA pointed out that the state budget can't fill the gaps for, have to do with gender affirming care no longer being allowed as an essential health benefit. And the state is still kind of trying to decide if that's an area they will fund outside of federal Medicaid dollars. The tax credit reconciliation requirement, and the end of the special enrollment period for folks who were at or below 150% of the federal poverty level, which is really significant for folks that rely on the ACA in order to get their health insurance. So narrowing that window to just about, I think it's 4 weeks now, will certainly impact people who have fewer resources and to be able to get that information, track down all the things that they need to be able to enroll. And then the mandatory shortened enrollment period starts in 2027, which is when it goes down to it gets shortened.
Question, so the tax
credit reconciliation, does that mean that people who are on OHA and get a tax refund, they take their tax refund?
I couldn't tell you exactly how they'll implement that, but it does have to do with that.
That's pretty crappy.
Yeah, it is. Yeah.
Can you repeat FPL?
The federal poverty level.
Poverty. Okay.
Yeah. yeah.
I figured it was something like that. I just
Yeah.
couldn't figure out what P was. Thank
Yeah.
you.
So what OHA presented to us was it's about a $385 million reduction in SNAP benefits. And that goes into effect now. So that's the food benefit, the administration of that, and then the whole SNAP Ed program. So if you have questions about that, reach out to OSU. They're grappling with, because they administer a lot of the SNAP Ed program here in the state. So definitely has far-reaching implications both to the workforce and then just the programs that they're able to provide. The total loss of Medicaid funding over the course of 2 years is about $10 billion to the state under the new what was passed in OBA. So between the reduction in provider taxes, reduction in state directed payments, healthier organ emergency services reimbursement. So that is the payment. So for folks who are not eligible for Medicaid due to immigration status or otherwise, there is a fund from Medicaid that pays for emergency services. So be that delivery, in the hospital or emergency room utilization. There's significant reduction in what they're going to be reimbursing directly to providers for that.
When does that take effect?
I'm not sure.
It's one of the things that I've heard about this is that it doesn't take effect until January 27.
Well, we're gonna go through the timeline here in just a
Okay.
second.
Do you know what the Planned Parenthood 1-year prohibition means?
Let me look back and find out. I can find out really quick, or I can't. We'll come back to that.
Yeah, yeah.
Okay. Let's see here. Okay, so this is what's happening in 2025.
Look at that.
Yeah. So applications, okay, so the timeline is, so the application here that's due at the end of this year by the state is for the Rural Health Transformation Program. The SNAP benefit, adding able-bodied work
Ooh,
without dependence
bow.
requirement. And there's, what is it? 8, how many counties is implementing this? And that started this month, I believe, in August.
Counties and I reached out to DHS to ask why Benton County was having a quicker implementation. It has to do with the because starts at a certain level. It's a
bunch of students.
Yes, but and most of the counties that are starting this are university, college counties,
Wait,
yeah.
You're saying that this timeline is faster for us than
Yes.
other places?
For the adding in that able-bodied
Okay.
worker without dependence.
So-
Adults without dependence.
Okay. Able-bodied adults without dependence. That's, so now in order to get SNAP benefits, you can. So if you have dependents,
There's a qualification process to go
Okay.
through, right? Like an
Cool.
eligibility and determination process that people have to like kind of read, attest to.
So I can speak a
Yeah,
little
go
bit
ahead,
to this,
yeah.
because when I first moved to Oregon, I was on a SNAP program that did have an ABOB restriction. So that's how when you hear people say ABOB, that's what they mean.
ABOB. Yeah.
And so basically what it's saying is if you are an able-bodied adult without dependents,
Mhm.
then you have to attest to the fact that you are either pursuing education, working at least 20 hours a week, or looking for work. And so for people who are not working or going to school, they will have to attest to the hours that they spend looking for work. And that has to add up to 20, or sometimes there's a number of applications that they can put in that supersedes the 20, so if they're applying for multiple things. That's how it used to be set up, and I'm assuming that it's very similar in that
Well,
way.
I mean, when I was a student at one point, you couldn't even get SNAP, or they called it something else back then, unless you had a job and you had to work part-time, which I did at one point. And I got
We're
like
going
20
backwards.
It was $25 a month. Like, it's not
I have this.
significant.
Sorry.
Sorry, yeah, go
I
ahead.
have this specific language from TA, so why he said we've been using discretionary exemptions and waivers to hold off on re-implementing ABOD since the end of COVID. We're starting to run out of these exemptions, so we're beginning to implement ABOD again in specific counties. Typically, the exemptions and waivers we have remaining are prioritized based on unemployment rates, so counties with lower unemployment rates.
But have they looked at who's actually using the SNAP and unemployed? Are they, sorry, okay, yeah.
Yeah, I'm doing my best not to be very mad right now.
All motions are welcome.
Yeah.
So some other kind of just significant things that did start this month is DACA recipients are no longer eligible for marketplace or OHP bridge programs. They had to implement that right away. So that just went into effect August 1st. And then in 2026, the qualified migrant definition is updated beginning in January, and we'll talk about that in several slides here in a few minutes to kind of give you a little bit more information on that. The emergency Medicaid limited reimbursement that we just talked about, that goes into effect in 2026. The work requirement, if the state doesn't request a waiver, which OHA did in a meeting that we had a couple of weeks ago, earlier in middle of July, said that they are working on applying for the waiver, which would defer that until 2027 to add that work requirement in, which is similar to ABODs, right, in order to be able to get benefits. Then states are now going to be required in 2026 to pay 75% of SNAP versus right now it's 50% in the administration of the program. And then the caps on premiums and tax credit repayment goes away. The expansion of, I don't know, what is HAS eligibility? I'm gonna think.
I suppose it's
How?
HSA always.
Oh, HSA, okay, thank goodness.
HSA.
Okay, autocorrect.
Over and over. again.
Spelling,
I can't
okay,
get it to-
okay, perfect. I'm like, I don't know what that was.
Which one is that?
And then the premium tax credit goes away as well.
Okay. Thank you for your time.
Yeah.
Okay. Work requirements.
Uh-huh.
So this is escalating ABONs or
Well,
what,
this
so
is,
this
and
is,
this is for Medicaid.
okay, this is Medicaid.
Yeah,
not-
OHP,
Okay.
yeah,
Okay.
yeah.
And so the emergency Medicaid limited reimbursement, that's what we were talking about on the last slide.
Right.
And so when we say 2026, do we mean January 26 or do we mean,
Yes.
okay. And
But the waiver for work requirements would then delay it till January 2027. If the state gets approved.
okay, so the state could large could get a
And
waiver.
the reason is to help states figure out how they're going to implement the verification process
Okay.
of work requirements, right? So
Okay.
and the language, it's like, it's very nuanced. So what's in the bill really pushes, it is not the onus of the individual to prove that they are, because previously, and maybe this was your experience, I was in Indiana whenever I was a young starting out adult with a child. It was a form you just filled out and you could submit it, and great and fantastic. Now you're eligible or not eligible for your benefits. The wording in the bill requires the states to validate the information. So that means that it isn't just, so how you verify that you're doing those things gets a little bit more complicated.
Yeah.
If that makes sense.
Okay.
Which is why the waiver is important,
Take a
to
deeper-
be able
So-
to figure that out.
There's also, I've seen it on social media, I've seen it, you've heard pundits talk about it, right? The fact that if we get this waiver, this isn't happening until 2027, which is after the midterm election. So it's a very much a sleeper pill here about this bill. Of people aren't going to be able to get their reimbursements, but they won't feel that until for a couple of years.
Well, 2 months after the November 26th election,
Yeah. Okay.
Okay,
and that's just a coincidence.
Yeah, I bet that's just, yeah, there's no intention there.
And I don't know how similar, but a couple states have tried this. Arkansas and Georgia,
there's several, many,
And-
yeah.
like several years ago,
Mhm.
and I'm not sure they're still doing that because it didn't.
Well, the return definitely wasn't what they thought it would be, and it
Yeah.
cost the state a lot of money to implement. And so, definitely that is true. But that's also why many of those states also withdrew from expansion, Medicaid expansion entirely because of that, administrative burden. We're a Medicaid expansion heavy state. I mean, we have the highest insured rate in the country, I believe, of individuals, or we're number 2.
Which
Um,
is,
So Medicaid expansion was whenever the Affordable Care Act was passed, states had the opportunity to expand their Medicaid population. Yeah,
What's the rate? I think.
last number I saw was 96%.
yeah, yeah,
Insured.
yeah, in the state of
Dang.
Oregon. Yeah,
Okay.
yeah.
And why we don't tout that more.
Well, a large reason for that is because of Medicaid expansion. So the federal dollars that help supplement that big portion of folks. So now all of the Medicaid expansion population will be subject to work requirements and these redeterminations. So in 2027, so we have a Medicaid 1115 waiver in the state, which allows us to for several demographics, we allow automatic enrollment and do not require redetermination to happen. We can keep that waiver, and or we've been told so far anyways that they're going to honor the waiver. They will not be issuing any new waivers. 1115 waivers is what CMS sent out a notice in July to state Medicaid folks. But we do anticipate that we can keep our current one through the end of 2020, or it's like October, I think,
Oh,
September 2027.
7. Okay.
So we won't have to implement redetermination every 6 months until the end of our waiver, which in other states will have to start in January.
Because I remember this is something I became aware of a few years ago. It's just like the amount of money that goes into reminding people
Oh,
is insane.
Yeah.
And it's
Yeah.
the cost benefit here is it's
in states that have a high, that are rent burdened and people are, having to shift residences frequently and often,
yeah.
it particularly impacts, these communities that are vulnerable to.
When you live in multi-housing, the mail person is often
Right.
puts mail in the wrong boxes
Precisely.
all the time.
Yeah, so you may not know that you lose benefits until you show up to use your benefits, right?
Or get a bill later.
Or get a bill, yeah, so. Again, lots of things happening in 2027. The reevaluation of the monthly SNAP allotment, so there's potential for that to go down again. And then the end of premium tax credits for health insurance for non-US citizens this way as well. So then in 2028, a lot of things going on here. The home equity limited cap to $1 million for long-term care services. So that's a big deal in places in terms of what Medicaid is willing to pay for folks that are entering and transitioning into a long-term care setting. That will have a big impact on your aging population. New home and community-based services waiver option for folks versus moving into a skilled nursing facility. So some possible options for folks to avoid having folks go into nursing homes, which will put a little bit more burden on the state in terms of regulating and making sure that qualified folks are taking care of our elders. Cost sharing for Medicaid also starts, so co-pays, if you have a Medicaid program, starts in 2028. Just as a note, a win for community health centers that got put in the bill, you will never have to pay a copay if you go to a community health center. So anyways. But if you go to the Corvallis Clinic, you will, so,
No shade,
Yeah.
moving on.
and then, the end of the automatic re-enrollment, which I'm sure if you all have heard that, this is a benefit of what we've done with the marketplace is, to keep people enrolled and insured is it just automatically does that for you. I'm grateful to be automatically enrolled in my health insurance here. And so it will, if we didn't do it in HR, trust me, I would miss that deadline every year.
Yeah, no, for real, yeah.
And then 2029, the new system will be in place to prove that there's an idea that there's a lot of folks that are enrolled in multiple state Medicaids. I don't know if that's true or not, but there will be a new system in place for that. And then penalties for erroneous excess state payments will be in place. So the state has a score in terms of so they go through similar processes that we do with CMS where their billing and coding and reimbursement has to be below, I think it's 10% or below in order for it not to impact your reimbursement rate from the feds. This is a new thing. Currently, I think OHA's is 14%, I believe, if I recall the slide. So there is definitely some work to be done in order to get that down below 10% to ensure that there's no penalties or reduction in the overall funded amount that could come to the state. So that's in a nutshell what OHA shared with us. If we were to summarize that into how many slides was that? 5?
Yeah.
Okay. So the next thing we want to kind of just touch on is the Personal Responsibility and Work Opportunity Reconciliation Act. In the Clinton Welfare Bill in 96. So when this was put into place, it was essentially put together to define what federal public benefits were and transform, the U.S. welfare system at the time, making sure that there's clear restrictive eligibility for folks that were receiving Medicaid benefits. And it has impacted housing benefits, Social Security, SNAP, Medicaid, CHIP, and a few other programs historically. So that if you're not a qualified alien, you're not eligible for these services. I can't remember if this is on a slide here coming up, but there was exemption in 1998 where they very clearly and distinctly wrote an interpretation that excluded community health centers, Head Starts, and some USDA programs from being listed as a part of being federally public benefits. So that has stood since 1998. And now we're going to kind of go through what the terms are in terms of who's eligible for public benefits programs, federal public benefits. So obviously US citizens are, but they're not aliens, we're just citizens. But qualified aliens, and that's the term that they're using, to be very clear, this isn't a term we like, but this is the term that's in the bill, is lawful permanent residents that meet the 5-year bar. So you have to have gotten through your first couple provisionary residency cards or permits. Non-citizens who were granted asylum or other related reliefs, like at entry into the United States. So folks that, or refugees that were admitted into the United States. So you have to have that designation before you enter, not after you enter. Parolees, so those are folks that are kind of on an annual evaluation of whether or not they are getting their visas or their residency permits are being evaluated on an annual basis. Non-citizens granted withholding of removal or facing prosecution or torture if they return to their home countries. Some Cubans and Haitians, and then folks that have asylum or residency based off of domestic violence or human trafficking. And then folks that are a part of COFA. So those who are not qualified include anyone that doesn't have documentation to be in the United States legally, and lawfully present non-citizens like DACA recipients, individuals with temporary protected status. So these are folks who are maybe in the process of getting appropriate legal status. They're in the middle of immigration court, that sort of thing. H-1B visa holders, so all of your professionals that come here with visas. H-2A visa holders, which are migrant seasonal farm worker visa holders. Student visa holders.
So that was gonna be my question.
Mhm.
At some point, we've got a large international student population. So they're no longer allowed to use the health centers. Is that
That under this rule, that would be the case, yes.
so, and when does this implemented? It says 26
Well,
October.
we'll go through that here in just a second.
Okay.
Yeah.
Timeline again.
That's
sorry.
okay. It's okay. And then again, of course, folks who haven't been here for 5 years yet that are, so what is federally public benefit? This is where it kind of gets a little bit sticky, is how it was previously interpreted. Was that it was looking at, if you look at that Part B part, talks about anything that is going to an individual, a household, or a family. And so the reason why things like Head Start and community health center programs, USDA programs were excluded from that was because they were grants that were going to entities and organizations. And so they went there and then they spent the money however they wanted to, but the direct benefit was not being given to individuals. So so this was in 97 and 98. That's whenever we got that final interpretation that excluded health centers from that. The new interpretation added about 44 new programs across the country that are now considered to be federal public benefits. I do have, so there is a public comment period right now that ends on August the 13th. I just this morning was given a copy of a template for sending public comment. I would ask, I mean, this is late in the game. Granted, I just got this today. I don't know if this is something that we could get on the agenda on Tuesday, that you all would be willing to approve sending a letter through this template for public comment.
Deadline's next.
It's Wednesday,
next
so
Wednesday. Yeah.
Tuesdays are day if you're willing to do that.
I mean, this is a public meeting right now.
Okay, if you, yeah.
If you guys wanna,
Yeah.
Under other,
Under other,
I'd like to
to see it, I can get it to you. I'm like,
it was like advancing.
that is the federal registration. I can- I can send you the template. I just got it right before the meeting, so I haven't updated it with any of our
We'll talk
information
more about adding that on the
on
agenda.
Tuesday morning.
Yeah, I'm very supportive of it. I just would like to read what I'm signing first.
Absolutely,
Makes
understood,
sense.
Yeah.
understood. Okay, so the new programs that are being impacted are community health center programs, certified community behavioral health clinics, which is a federal program similar to CHC's for behavioral health. There's a few of those in Oregon. Community mental health services block grants that go to state, so that's our CMHP. The health center program, it's important to understand that they called it the health center program and not the 330 grant. Because they're including all program services and not just the things that we have to implement, like the sliding fee scale. So it wouldn't just be that folks couldn't access the sliding fee scales, that they can't utilize any part of the program. If that makes sense, yeah. Work with SAMHSA, substance use disorder, the substance use prevention treatment recovery services block grant that go to states, Title 10, WIC, they listed in here, and vaccine for kids. They had, so this is, they took it, well, this is the, this is where today. Yeah, well, it's not late, it's late from after. So what happened initially is they issued this federal registry, and then there is, I can go to the next step. There are there's legal action that states have taken, Oregon being one of them, to put a temporary injunction in place. After that was filed, the Attorney General's office issued a statement saying what, not the Oregon Attorney General.
Oh, okay.
Sorry. Pam Bondi's office issued a statement because people were just like, what is included, what isn't included? And it used to be that there was just so many loopholes that other programs that folks depend on could exist. And the statement that her office issued basically said that the only thing that isn't listed under federal public benefit is these emergency Medicaid service. So what was in the OBA bill, so for delivery and emergency room services, those are the only things that apply to outside of PRORA. So if you are a unqualified alien, you can still get the benefit of those emergency services dollars. But all other benefits, if it's not one of those two things, then it's not a part of the loophole. If this is confusing, I can.
You can have a baby, but you can't go to the doctor for like a cold.
Well, you can, but they
Can,
don't.
but-
They'll pay for a baby, but they won't pay for a doctor's visit.
Yes, but they won't pay a lot of money for having a baby. I just want to be really clear. Here, it doesn't cover the cost of
Okay.
delivery at all, but it is some reimbursement for that.
Okay.
So this is being challenged, and what's being challenged is what is being defined as federal public benefit. So like they're saying you've gone way too far, you're including too many things. So there is a stay in place for states that did sign on, but that's only in effect until September the 4th. So we hope to hear more soon.
Yeah.
Where we are more complicated than other community health centers, is that we're a public entity and we don't have a choice whether or not we enforce this. There is a clause and caveat for 501c3s, nonprofits. It's kind of a don't ask, don't tell, in that if you don't know someone's immigration status, you can provide the service. Once you know, you can't.
And because you're governed by a
Because we're a public entity.
public entity, you have to ask.
We have to. Yeah, so
The valid.
We're
there would be
waiting.
Some kind of validation.
yes, we're waiting, but we're waiting for guidance from
Yes.
FERSA and BIPIC to tell us exactly how they want us to implement that. The hope is that public comment is so huge that, that folks will, that they'll take a look at this. We would hope that we can get the attention of, Secretary Kennedy, but we don't.
We just don't know.
Yeah.
But
That's our.
that goes back to who had asked anecdotally to have these examples, so when she's able to
Go and talk
speak
about that.
to Secretary Kennedy in a few weeks, that she, as that.
Wait, you're gonna talk to, wait,
No, the
Well,
Congresswoman, she asked,
okay, sorry.
she has
Yeah.
asked us to pull together some examples to be able
Well, that'll be.
to personalize.
Yeah, well, sure will. We do have changes coming. We had anticipated that there are changes coming to our terms and conditions on our grants. So there's just a few we're gonna run through really quick. Some of them are easy to implement, others are gonna require a little bit more conversation. Just so there's obviously a lot of debate. When do these terms and conditions apply? If it's a previous award, can you implement new terms and conditions? And the interpretation that's being held at this point in time is that each time you draw down funds is kind of a new opportunity. So like that money sits in there in the payment management system, and every month we draw down funds. So each time you draw down funds is a new opportunity to say you accept the new terms and conditions. So that's kind of the way that things are looking, but these are new. They just came through in July. So we have seen, we talked about this back in February. It's okay if you don't remember, but for all federal grants, with the exception of the ones in Health and Human Services, they already implemented a transition to 2 CFR Part 200 around uniform guidance regulations. Health and Human Services grants start that as of October the 1st. And it did do some good things, like for folks that have small grants, you don't have to do the single audit. If it's less than $1 million, previously it was 750,000. So I mean, just a few things there. But the important thing for us in that what they're emphasizing and underlining in the terms and condition is that they're allowing the termination of awards that no longer align with program goals or agency priorities. So this will now apply to all federal grants, including those inside of Health and Human Services. So that includes the block grants that go to the states. There is new language, which we never have seen quite like this before, highlighting the False Claims Act. Just reminding us over and over again that if we are knowingly attesting to things that we know we're not complying with, that the Department of Justice will pursue it.
Makes sense.
Yeah, this is important. We think about that all the time. We want to sign things that are true. There is information also about the civil rights requirements, a new term and condition saying you will follow the rules and regulations under the Office of Civil Rights. Considering that there has been no change to civil rights since Donald Trump has come into office, this is fair. As long as we're continuing to comply, this is fairly easy. This is separate and different from a DEI thing that we'll talk about here in a second briefly, but until there are changes to those fundamental civil rights that are written there through OCR, we are complying with them. So we feel good about attesting to that.
But can
Yeah.
that's the part about administration is actively pursuing cases related to healthcare providers' conscious or religious rights?
So, yeah, so this is specific, so it's kind of this reverse discrimination things. We've seen a lot of cases come before the Supreme Court, and the Department of Justice have picked up, different states have picked up, and then now on the national level. specifically around defending providers' ability to not do things that they feel like violates their personal,
Got it.
yes.
I was thinking, if you're religious and you don't want gender affirming care, don't get it. But it's
Yeah,
not
yeah,
the right
the,
around
it's
it.
the other
Yeah.
way around, yeah,
Physical reverse discrimination.
Yes.
Discrimination.
yes,
Correct, right?
yes.
Right.
yes.
It's, yeah.
There's another term and condition around gender affirming care, and it has to do with not promoting gender ideology. So this is really only tied to Title IX, so education related entities. Because health centers also qualify to be teaching health centers, it's now included in all of our terms and conditions, but specifically calls out only if you are subject to Title IX, which we're not. We're not a teaching health center, so we don't need to worry about that. In terms of providing gender affirming care, we're still protected under the temporary injunction that the state has in place until that case gets settled. We continue to operate as is.
So
We might not get reimbursed for it, but we continue to operate as
Okay,
is.
so gender ideology,
Uh-huh.
whether that's, hey, there's multiple genders or there's just two, both of those are an ideology.
Well, that's your interpretation of that.
Logic,
Uh,
Sorry, go, please
That's
continue.
okay. And then there's some other things here around a DEI and a new statement that was issued to health centers from HRSA last week, referencing back to the HHS grants policy statement. And just really specifically calling out activities, DEI related activities and their expectations for that. There's an attestation that we have to sign with that. There is quite a bit of, this is an area where health centers are very, very concerned about this. This is the language from the April 16th grants policy statement from Health and Human Services, just kind of defining what they believe to be DEI related activities. And by accepting the grant award, so whoever the entity is that accepts the award, that you attest that you're not participating in any of these things. So this is one of concern. There was an update that was issued on July 25th that had a significant amount of that language redacted or just wasn't there, but it looks like it just was deleted in the middle of a sentence, like, so it's strange, but wait, if you'd like to know, I'm gonna go here, to the next slide. An enormous amount of thanks to Benton County, Oregon Community Health Centers who brought the updated version of the grant. We discovered that,
Wait.
and
For this country.
Oh,
Christine and I discovered this and.
Are you guys the one that read it? I mean,
Well,
Well, they're just.
we're just, comparing and trying to really understand what the implications are for us and how to move forward. And so we were the first ones that noticed that there was a new one that had been issued. And so anyways, this is just our little claim to fame, also scary. that
yeah,
we're the
I
only
don't like that we got till that. I mean, good. I'm glad you guys are reading it, but that doesn't feel good.
Yeah, no, it doesn't. It is also scary. Anyways, just to be clear, the fact that that section was deleted, middle of a paragraph and sentences, doesn't necessarily mean that it is, gone. It just means that somebody published it and there's intention for it to be, enforced. So a few things that we're still watching. We have a few minutes here. We're going to get through this so that you may have noticed or heard about the executive order on homelessness and mental health that was issued on July the 24th. Really talking about this. What did they call it? Ending crime and disorder on American streets. Suggesting that overwhelmingly, the majority of folks on the street are addicted to drugs and have a mental health condition or both, suggesting that homelessness is a long-term, that homeless individuals should be moved into long-term institutional settings for humane treatment through civil
Sounds-
commitment.
Sounds like a
Um,
concentration camp.
When someone says humane treatment,
That usually
I
means,
mean, it's, the words are right, the implication is bad.
yeah, trust us, it's gonna be humane.
Humane treatment is what you talk, is like a kennel.
So there's a lot of concerns about this executive order. I'm not aware of legal action that's been filed against this yet because it hasn't come with any policy.
Yeah, what do you,
It will be,
It will, yes, yeah.
Where, who's gonna build this? Where are you gonna get the money?
The
Where
state
the
will
work
be responsible.
oh, cool.
I'm sure. So, and then they do talk specifically though in this about penalizing states that have, programs similar in the state of Oregon around, legal use of some drugs or non-criminalized, you know.
Are we going like all the way to cannabis, or are we going to, like, cause that would be wild at this point.
Doesn't call it out.
It doesn't,
Definitely deprioritizes harm reduction.
Harm reduction,
talks down
yeah.
on that, and housing first models.
Let's
Yeah.
take all the
In
stuff
favor
that
of
works and just shove humans.
Yeah, it's very different.
Yeah.
You need a fidget spinner, that's how I'm getting.
I have a stress ball, but I burst it a couple days ago, so.
What does that say?
Yeah, so this is just a reminder, executive orders do not create, amend, or change existing law. They're just words, right? This was a good time to insert this slide. Thank you, Christine. To remind us.
Along those lines, your stuff's way too complicated, so I'll talk about tariffs.
Oh, okay.
And, I mean, he's doing this and the 15%,
Thought it was
there's a
50%.
decent chance, and I thought it'd come out, Trump lost at the first level of court cases. You can't do this.
Mhm.
And it's in the second level, and that decision could come any time. Because he's basing it on a 1977 emergency clause,
Mhm.
and if I read it right, you can't do it countrywide,
Right.
which is obviously doing.
Mhm.
I assume sometime it ends up in the Supreme Court. So all the stuff that he's talking about, India, you're 50%, and if you don't shape up, it's gonna get worse. You can't do that. And so, they may not be worth the paper they're written on. But, anyway,
Which is all very true. I think, as we visit later on today, I think the big question is just whether or not states, local communities, nonprofits, community partner organizations, if they can sustain their operations while things get fought in the court system. And that's really a big deal. And also ensuring that the legal action that is being filed is not going to be thrown out on technicalities, which is another big concern with a lot of the many things that are they're just getting pushed back down to the lower courts for technicalities, which just keeps everything churning longer.
and the other side of that is withholding funds.
Right.
Well,
So,
you can't do that. Well, no, we are.
right, yeah, legality kind of goes out the window just for.
One of my brother's favorite phrases that I adopt is it's all playground rules. Like how are you gonna stop someone from not giving you money? Like, at what point does a court order, do you just disobey a court order and who's gonna enforce that, right? The quote that Andrew Jackson never said of like, let the Supreme Court enforce it. He never said it, but it's something that's permeated our culture for a long time, right? So, yep, doing great.
Yeah, so just, we're almost done here, guys, I promise.
We get into the fun stuff.
We did that at the beginning.
Yeah. We'll end on that next. So the Rural Health Transformation Program, as you know, there was, or I should be aware of, there was quite a bit of cutting to, or the impact to the Medicaid cuts will have big impact on the rural healthcare infrastructure. This was added in, Senator Murkowski from Alaska, really was looking for something to help rural folks to win her vote. This wasn't exactly what she thought it was. But this is it's basically a grant program. It's going to be $50 billion over 5 years for kind of new projects, not to really sustain operations for critical access hospitals, rural health clinics, those sorts of things.
So close your clinic on Thursday and reopen it on Friday as a new
Right,
clinic.
yeah. Well, I don't know that you want to do that either, so.
Just an idea.
But there are 10 provider types that are eligible for these funds, including community health centers are in there. Indian Health Services are also in there as well. States have to submit a work plan to CMS by 12/31 in order to be eligible. What makes this one quite a bit different is that the funding, how this is going to be funded and distributed is not quite what was also originally proposed, in that now the word is that CMS Administrator Oz has autonomy over
Right, I forgot about that.
how funds get distributed.
Dr. Oz. Yeah, Mehmet Oz. I forgot about that.
Another big thing has to do with data sharing between CMS and ICE. That they have reached an intergovernmental agreement to share personal information on Medicaid recipients. We are part of a lawsuit to stop that from happening, or to prevent Oregon from having to share that information. So we share aggregate data, we have to. We share claims data that's de-identified with CMS, but this, and in some states, Washington accidentally shared their data. It's been a big deal, but it has had a big impact on folks that are unqualified aliens enrolling in programs like Healthier Oregon Plan for undocumented folks, because they're reluctant to share their information with a Medicaid program. Yeah.
Okay.
Some other things, this is, I think maybe last time we shared about the vaccine review committee, that was dismantled and new appointments were put into place. So in June, the Supreme Court upheld, so this is kind of where, you say the Supreme Court's upholding things, cool. But the Supreme Court upheld an ACA requirement that requires health insurances to cover certain preventative services. This is why you get to go for your annual wellness visit with no copay. This is why, you can get your mammogram or your colonoscopy or your PSA checked, all of those things on a regular basis without copay. Statement clause, as long as the U.S. Preventative Services Task Force members agree with what those services are. So then on July 10th, the U.S. Preventative Services Task Force meeting was canceled. Update this week, all of those members are being removed and new appointees are being put in place. So if you have to uphold the law, then you just change the people and the requirements. So now we may have different new, what is considered to be appropriate preventative screening definitions in place. Does that make sense?
I understand.
That's the wrong thing to say.
I didn't lose you.
Sorry.
Yes or no? Yeah.
Do you understand what has been said? Yes.
But, yeah, okay, I'll just keep going here. So yes, there's a lot to track. We're doing this. We're spending a lot of time paying attention, and trying to be, proactive, at least preparing behind the scenes for things that we know, are going to reach our work soon. We've been waiting on direction from HHS and from HRSA and from the Bureau of Primary Healthcare. We're starting to get that. So as that's becoming clear, we're trying to figure out exactly how we will respond to these things.
But you have a national network that, well, this came down, what do you think this means?
Yes, and they're very responsive. They respond to our emails and phone calls. We were on the phone with one of our partners in DC at 10 PM her time, because that's whenever we discovered the other thing. And she said, I'll call you right now. So, I mean, people are paying attention, and this is extremely concerning to everyone. But it's just hard to keep track of because so much is happening so fast.
Yeah, I know I've said this in other spaces, but it's one of the only spaces where a deep and comprehensive level of coordination and sharing exists. And so we're applying a lot of the things that Lacey is learning in preparation. We're learning things through her connections and not through I'll just say that the communication with OHA has looked very different, and I know that they're doing a lot of preparation, planning, and prioritization on their end. But there hasn't been anywhere near the same level of like technical assistance or interpretation or just really ongoing and focused support as you've had, and it's benefited all of us and will benefit the entire county.
Yeah, and the Oregon Primary Care Association, individual community health centers, I mean, we're sharing the same information with OHA. We have partners there. We have people that are in this work with us. They're waiting on the same things we are, which is guidance from these agencies, federal agencies, on how to implement things. They just don't have the same advocacy networks and groups like you guys have with AOC and others who just kind of help you get organized and rally around the right things and think about things. The states don't have that same level of organization to be able to know how to do that. And so, yeah, so we're grateful for our partners. We are not alone, which is comforting, I suppose. But just a reminder, this is who we do the work for our community, and our patients. So anyways, more questions?
No. One thing that I just want to add so that the commissioners are aware, from the very start, I don't know when we had our first like manager and then staff conversations, but we want to make sure that staff are not in the dark. This is creating incredible anxiety and stress for everyone. And so Lacey and I, to a lesser extent, have done such a great job of collecting and organizing the information, have come together to make sure that folks are aware of what we're concerned about. You know, we're not causing undue alarm, but when things do change for the worse, folks will at least have some sort of.
There's a foundation,
Yeah.
at a minimum of knowledge of what's going on.
Seems like, one of the themes in the Bubba bill.
I call it OB3, but go ahead.
Bubba,
Bubba.
is shifting costs from the feds to the states, and
Yes.
to the individuals.
Yes.
Just like
That's the
throughout
thing.
the whole,
Mhm.
that's, and wondering, it's great having, Val Hoyle going to bat for us, or Wyden, who may have a town hall sometime this month.
Yeah. I was,
The 16th.
did you get an actual date? Okay,
Okay,
I was,
I think it's tentatively being planned for the 16th. I'll say that.
okay.
The change is not my fault.
they, just opportunities to share our concerns, and I'm wondering about, we have reduced our federal government relations effort. And wondering with the billions of dollars that are in play, and maybe we get them, or if you say the magic word, you get them, but if you say bad words, you don't. And I guess I'm wondering about that cutback at the federal level.
Sure, I can speak to that a little bit. You know, it was a tight biannual budget
Yep.
and we have three amazing commissioners and relationships with our federal counterparts that we will also lean on. We still have a small contract with Michael Skipper with and they will give us and provide us technical assistance, and also we can always do a short-term agreement if it really gets dire near the end and we need someone actively on Capitol Hill, following some of the very nuances of it all. It was a hard decision, but at the same time, we still have we still have them on the statewide level. And we're gonna be looking at each and every one at the table to help us push through and find those assistants. I mean, Lacey has been incredible, following even 2 or 3 sentences that says, "Ooh, that's gonna affect Benton County." Because we are a little bit more unique than some of the other counties in how we're set up. So we're committed to it. We're following it closely. But you know, those were some of the essentials. It's gonna be a tough couple of years to call that, but we are well aware of it, so.
And maybe the good news is, this is was a 1,000-page bill.
Yeah.
And, the folks that voted on it have no idea what was in that, other than, they were told to vote for it. And maybe, oh, we get tax cuts, some of the highlights, but just some of the things that you're going through, no clue.
Yeah, I mean, they're not getting front page coverage, that's for sure, right?
And,
Yeah.
and part of it is, what are the roots?
Right.
Well, we don't really know. Maybe this and this. I think this is, well, this is tax law changes. It may take 2 or 3 years to actually go through the rulemaking and clarification and, okay, this is the law and this is the actual effect. And to try to do these massive changes in our healthcare system. Your example of the information sent out and it ended in the middle of a sentence. They were really thoughtful on this one, I mean, that's after they worked on it and.
Well, that's an agency document. I mean, it goes though without saying that this is the most significant bill ever passed in terms of healthcare delivery in the United States, even beyond the impact of the Affordable Care Act. So that, I mean, that's not, I'm quoting people.
Yeah.
In terms of things to be, and you think about the impact that the Affordable Care Act has had over the last, 10 years right now, right?
15.
And that we're at 96% insured in the state of Oregon. This is significant. This is huge, and it will, the same way that ACA has been protected, it will take an unwinding to undo what was done in 1 week. It will take more than a midterm election to fix what's been done because it will have to be overturned.
I remember talking to a previous healthcare director not too long after the ACA was passed. He was talking about providing the same level of care and now we get reimbursed. Whereas before it was county costs. And well, that's a big change. So now, well, maybe we're trying to go backwards. Like I was saying, shifting the cost in the states. State's not ready for this financially. Sometimes.
Yep.
But I appreciate that you have a national network of, if 20 people are reading the same thing. Oh, did you catch this? What do you think this means? Keep us posted.
We will.
And how we can help or be involved.
Yep, we'll get on your agenda on Tuesday.
Yeah.
And you can send us a letter.
The letter will probably be nicer than I want it to be.
It will say all the right words.
Okay.
If you want to write one as a citizen.
I might.
You're absolutely, I mean, you're welcome to as a commissioner too. You can say whatever you want, I guess, but.
Yeah.
All right, any other comments or questions?
No.
Okay, I lied about the town hall, it's actually the 20th, I'm sorry.
Okay.
16th is furniture shares event.
Equally important.
Yes.
There's a joke in there that I'm gonna refrain from.
Thank you guys for your time. We really appreciate it. Thank you.
So with that, did you have?
No, I'm just saying in a note later today, we'll have a small meeting one-on-one with both the remaining commissioners. We met with the chair earlier this week on some other new guidelines that have come down. So hopefully you can go into a deep dive with any questions, and then we will planning on bringing it back to goal setting the following week.
So just with the theme of this meeting, when you talk about remaining commissioners, it sounds.
You?
Yes.
Commissioner Malone, Commissioner Shepherd.
Okay.
Chair Wise met with us earlier this week.
The remaining commissioners.
No commissioners have been.
Don't worry about it.
That's what I was.
Yeah.
Well, we still own a cemetery, so.
Jeez, okay.
All right, and with that, I'm gonna.
And there is space.
There is space for.
For rent, that is at least.
Maybe. I'm looking for revenue opportunities.